On the back of this handout, I've started doing several things. So I will try to keep adding to them as we go through. So kind of to demystify or debunk. And antibiotics are hard. There's just multiple details, and they shift depending in particular where you are. There may be resistance patterns where these won't hold true. But I did three things. One is I gave you a chart that at least shows you class of drug. Sometimes they'll give you the individual members. Cephalosporins are always going to talk to you in generations. So generations usually mean in any drug type is that when they first come out, they don't call them anything. But if they then make modifications, major modifications to address a problem with a class of drugs, then they'll call them second generation. Okay? So what you see with the cephalosporins is that as you went from first to second to third, then the gram-negative coverage got better and better and better. Okay? So now we're up to 5 generations. So usually the coverage is more broad, or they're addressing also a resistance pattern or a specific group of like gram-negatives or unusual bugs. So that's that one. The next one is I just started giving you antibiotic class, and then particularly in the drugs that I mentioned in this handout, I've listed them there so you can start linking. It's good if you can think class, okay? With antimicrobials, its class is important. And then starting to know where the common ones that you see all the time, which class they belong to or which generation they belong to. And then on the back I put common microbes that will, because I thought, well, if I put gram-positives, well, you know which ones those are. So I don't know. Is that something that if I say gram-positive organism, you would know, you could tell me what fits in that category? Some yes, some no. I see some shaking heads. So I start to give you some of those in that last chart.
Thank you. This is helpful. Yeah.
So do not, please, these are reference. But the more you start making yourself go back and say, okay, if she says staph, what is that? Okay, your major gram-positive. So your skin organisms, your staph, and your strep. Okay. All right, so I told y'all nose today, it's ear. I don't know why I kept saying nose, but today I'm following up Dr. Berryhill. Isn't he wonderful? I can tell you, he is a great doctor. I went to him. I had that benign paroxysmal vertigo. Oh, it's awful. But he cured me. That little procedure they do, it works. It works. It's very good. He's excellent. And he has a wonderful PA that works with him. He's top notch. Okay, so let's see. So here's the topics we're going to do today: otitis externa, otitis media, the chronic suppurative otitis media or chronic type, the acute mastoitis. Mostly we're going to focus in children, and then it's common in kids, not so common in adults. So I'm not going to spend that much time on the adult side. And then the vestibular neuritis, and then Meniere's disease. Several of you, I noticed as we went through, said that you're really interested in pediatrics. So I'll just tell you, I love kids, but the patients I love taking care of are chronic diseased adults. So if I seem to be sliding or you really have more questions, please bring those up. I'll do the best I can with peds. It's just not my area of where I have spent time. So I don't have that more practical knowledge. I can give you book knowledge. But I have a lot of good friends who are clinical pediatric pharmacists, and I can always go to them. So you can certainly ask for more if I don't seem to be hitting it as much as you'd like. Okay, so instilling eardrops, just like instilling eye drops, I gave you, I posted a sheet to this. So it's pretty easy. Gives you some tips, I think, on children as well in terms of laying them down, how to position the head. I think the great thing I took away from this that I don't think I ever really did is just warming it up. I didn't realize how much of a dizziness or vertigo you can set off in people if you instill cold drops. So warming them in your hand. I will say one thing. I don't know, is it, you want the door open? Is it warmer or colder? It doesn't matter. After I had a patient do this, I've been more careful about telling people to warm. When I say warm something up to you, what do you think about doing? Put it in the microwave. Your patients will do that. We had a lady who we could not figure out why in the world her insulin wouldn't work. It'd work when she first started, and then it would go to nothing in quickly. So insulin is a protein, so it's just like any piece of meat. You could cook it, you could freeze it, but you could certainly cook it into not working. So what we figured out she was doing is that she would, she didn't put the insulin in the microwave, but she put a bowl of water, brought it to boiling, and then she would stick the insulin vial down there. So be careful when you tell people about warming up that you make sure that they're not going to, bring something to such a temperature that they would hurt themselves. So with these, it's simply in their hand long enough if they've had it in the refrigerator to warm it up. Okay, let's see. All right. So here's our major bugs. So Pseudomonas is the most common. So Pseudomonas gram-negative, always a problem, a terrible pathogen, and it is a nasty infection whenever it occurs. So it's the most common with otitis externa. So staph, so your skin bugs can certainly be a problem, and other gram-negatives like your Enterobacter, Proteus, your antifungals, Aspergillus or yeast with the Candida. So all kinds of different things. Bugs can get in there. So treatment agents. So you can, Dr. Berryhill had in his slides about using drying agents or astringents. Those would be like the acetic acid, aluminum acetate. If your parents ever made up Domboro solution, have you ever done that? Taken the packets, mixed them with water, and then you dip a gauze in it. And it's a very cooling, soothing, especially when you have things like poison ivy. So it has an astringent activity and also antibacterial. So I was asking the PA faculty upstairs, when would you use this over an antibiotic? And they said they'd almost always go with the antibiotic first, and then if they had a lingering or ear that would not respond, then they would, after that, follow it up with these agents. Even though the acetic acid and the aluminum aluminum acetate have fairly good antibacterial and antifungal activity. But, so that was kind of their guide. I don't know if Dr. Berryhill gave you a rank order, here's where you'd start and here's where you would go. Most people will start with an antibiotic, or the second one down there, that neomycin polymyxin, called cordyceporin. So it's got the steroid in it is very good with inflammation. So it immediately starts giving them relief, and then you've got the antibiotic. The neomycin is an aminoglycoside. Polymyxin is just a broad spectrum antibiotic, and then the hydrocortisone is the steroid. Thing with neomycin, anytime you see those mycins, those are aminoglycosides. You think ear toxicity. So a lot of hearing losses occur when people use aminoglycosides and the person gets toxic or has a severe adverse reaction to them. Okay? So if they've got a perforated eardrum, you do not want to use it. Don't want to get it past that barrier. Okay. So because Pseudomonas is our big organism that we're going to worry about, that's why we're going to use the quinolones, because they're excellent against Pseudomonas. Okay. Makes sense? So see those oxycin, ciprofloxacin, ofloxacin, levofloxacin, those are all those fluoroquinolones. And these come in eardrops. as I was going through it, I remembered things that I hadn't thought about in a while. You've got to, or at some point when you're talking to patients, is make sure that they understand ear and eye, okay? Eardrops in the eyes are bad because they'll burn them. They don't have the same isotonicity or buffering systems in there that we have up for the eye. Most of the eye products will put an ear on it or something that will try to catch the attention of people. But people are notorious, I don't know what your medicine cabinet looks like, but people are notorious for keeping stuff that they didn't use at all. So they'll put it aside and forget. So just reinforcing that is to make sure that they understand it's for the ear. So fungal otitis externa, so we're going to use antifungals or agents that also have maybe yeast activity as well. So again, when you see that this part, let's see if I can get it. Azole, so this is clotrimazole. You can buy it over the counter now, it's Lotrimin. Tolnaftate, if you've ever had foot fungus or athlete's foot, that's what tolnaftate is. These are antifungals, but this in part azoles, they always have activity against a fungus or a fungal activity. There's quite a few of them out on the market. You see it right here again. So itraconazole or Sporinex is also one of those antifungals. So for here, you're going to use antifungal, they come in liquids. I know that there's powders available, and I saw Dr. Berryhill talked about powders. I would say that's unusual. That's probably what you're going to see with a ear specialist, not what you're going to see out in general practice. That's from my experience. And then you could use the acetic acid or the aluminum acetate. Those are the Burroughs solution or the acetic acid drops. Let's look in there. So on that second page, I gave you a table. I do not expect you to know those doses, but it just gives you, it kind of summarizes up the different products that are out there. And then did I put a duration of use? 7 days. So mostly 7 to 10 days on these.
Dr. Latassi,
Yeah.
in class you mentioned something called cordosporin.
Yeah.
What's your take on that?
That's good. That's this one right here. Neomycin, polymyxin, and hydrocortisone. I would say it's probably the go-to. A lot of people will use it. Just remember it's got that neomycin in it. It's inexpensive. It would be a good place to start. The ciprofloxacin, ofloxacin, they're going to be a lot more expensive. Okay, so let's move on to acute otitis media. You'll see this a lot, especially if you have kids in your practice. So the things we're going to want to do is first control and, not first, but control and manage the pain and eradicate the infection. And then we want to prevent the complications from occurring, especially in kids with hearing loss. And my son had lots of ear infections when he was little. And by the time, I think at about 8 months, we finally put tubes in his ears. And the ear specialist I went to at that time, he said, I think he probably hears about 50 to 70% less than what you hear, just because of the amount of fluid behind. And then he said, I think his walking and his speech will pick up dramatically after we finally get the tubes in. They were a godsend because we never had to use antibiotics after that. We would just put antibiotics in the ear if we needed, but we didn't have to do oral anymore after that. So I'm a big proponent of tubes with my N of 1 experience. Okay, so let's talk about pain management. Mostly I'm going to focus on the OTC pain relievers because they're going to be effective for the vast majority of children. So you have Tylenol and you have, acetaminophen, which is Tylenol, or the non-steroidal anti-inflammatories, and the one for kids is ibuprofen. So these are a little bit different. They're both good pain relievers, but they do it by a little bit different mechanisms. So Tylenol does a more central action and inhibits pain that way. Ibuprofen, or the non-steroidals, work on prostaglandin, inhibiting prostaglandins peripherally, so their ability to control pain that's due to inflammation is much greater. So Tylenol, you can give it for pain, for temperature, it's going to do very well. But if you have an inflammatory action or activity going on, it's not going to be as good as. Here is one of the doses I do want you to learn because it's just going to come up over and over again. So you might as well go ahead and learn it. It is for acetaminophen, is 10 to 15 milligrams per kilo, every 4 to 6 hours, max of 5 doses in 24 hours. The big problem with kids, now they don't drink, but the big problem with Tylenol is its liver toxicity. And it can be lethal if you get too much Tylenol in a short period of time. So the amount the safe amount has been going down and down and down over the years. So that's one of the reasons to have a max on the dose. Several years ago, they used to have the product for kids was for not kids, but infants, was a very concentrated solution, or liquid, because they wanted a small amount to get to the kids. And then they had a different concentration for toddlers and young children. Well, what happened is mix-ups you got several kids in the family, you got one for older kids, one for younger kids, so toxicities occurred. And so what they did several years ago is they just standardized all the Tylenol products that are in liquids are the same strength. So, remember when we talked about medication safety, one of the big problems is when a parent has to convert pounds to a dose. So make sure your parents know how to do that, and you could give them a kilogram for the kids, or help them figure out a dose, or tell them, here's how much I want you to draw this up. Always have them use a dosing syringe. Don't use the dosing cup. Most of these products now come with a syringe inside, but if they don't, gets lost, they can certainly purchase one in the pharmacy. It's also a suspension, so it has to be shaken well, and I'm going to go over just a little bit to reinforce that after we talk about the ibuprofen. Okay, so ibuprofen, very good anti-inflammatory, very good temperature reduction and pain relief. Overall, very good. Its main problem is just stomach upset. So those non-steroidals destroy some of the ability of the lining of the stomach to stay intact. So if you take enough of it over a short period of time, if you've ever done that, it'll start to mess your stomach up. It'll start giving you stomach cramping, pain. So giving it with food usually will help. That's not always possible with small children to get them to eat, especially when they don't feel good. And this is going to be limited. You're talking about probably 24 to 48 hours. This one, parents usually like, you don't have to dose it as often, but it is not recommended to use in children under 6 months. And from what I've read, they really recommend that you not use any type of fever-lowering medicine under age of 2 months, because neonatal sepsis could be missed because you're masking one of the big symptoms for that problem. I assume these are drugs you have some experience with, Tylenol or ibuprofen. So let's talk a little about them because they're suspensions. So what do you know about suspensions? If I say suspensions and solutions, what's the difference?
Suspension is when the drug is dissolved.
Solutions are. So the more clear, if it's clear, I mean, even if it's colored and you can look through it, that's a solution. So you've actually dissolved the active ingredient in the vehicle that's there. Okay? If it's a suspension, what color is it? It's opaque, so you can't see through it, usually, especially if you've shaken it up. So the active ingredients are suspended. So they can fall out of that vehicle if you let it sit there for long enough. So let me show you the next slide. So here's what happens, and here's where the problem lies. So A is more of a solution. You can see right through it, right? B and C are you've got a suspension. Those are suspensions. So if a suspension sits long enough, if you pick up the bottom and look at it, you're going to see usually a ring of the active drug or what they have made, even the fillers or other things in there, are going to settle to the bottom because gravity will work on it and eventually it'll all be in the bottom. If it can be easily resuspended by shaking it, then it's no problem. Okay, and that's what the last one looks like. It should be uniform. So suspension should always be uniform in appearance, top to bottom. Here's the problem. If I don't shake that, then tell me what you think the concentration at the top is relative to the bottom. Less. Okay, so if you half-heartedly shake or don't shake, you're not going to get as much drug in the top. So what happens is you use that bottle up. It gets stronger and stronger and stronger, okay? Always the problem with suspensions. So having patients, and you know, it doesn't take a lot of shaking to get it back in suspension, and vigorous shaking can actually sometimes disrupt some drugs. Insulin, you can't shake it very hard because the proteins will break apart. But what you can do is, even this kind of action or this kind of action, if you tell them, do it 10 times, give them a number, it gives them more of a goal and you'll get more consistency. Also with suspensions, if you roll them, sometimes you will get a better action than if you shake it up. So some kind of consistent every time doing that's really important, especially for drugs that can be very toxic. Phenytoin, which is a anticonvulsant, comes as a suspension. Notorious that patients will not shake it enough and you'll start to get toxicity as the patient uses up the bottle of their anticonvulsant. So I wanted to bring that home because it's a great, and it's good that we have that type of dosage form, but it does come with its problems if you do not shake it. Especially when we're worried about maximum doses in children. Okay. So I think I've covered most of these. Oh, the practice of going back and forth, Tylenol or Motrin, that came up several years ago. There are problems with that, so they were trying to avoid the toxicities of each, but the ability to give something to cover a child every 4 hours or so. I think there's good and bad with it. I think there's a problem if you've got multiple caregivers involved. Who did what? When did you do it? So unless they're going to be meticulous and kind of stay with it, I would say stay with one and avoid the other of going back and forth. But it's a common practice. Let's see. So reviewing with the patients the suspension, shaking well every dose, using the dose syringe, reviewing dosing per weight, adhering to max doses, and then whether or not to alternate pain relievers. Questions about that? Okay, so one other product that is mentioned is the antipyrine benzocaine. I brought it up for a couple of reasons. One is that topical anesthetics used to be fairly common, benzocaine drops. They took them off the market. The FDA recalled them several years ago because they had failed or had never produced safety data or efficacy data. But this product is still on the market. Antipyrine benzocaine can be very effective. A couple of things to keep in mind though. Use for kids 2 years and older. In younger kids you can get methemoglobinemia. So is that a term that you recognize, methemoglobin? Some yes. So it's methemoglobin can pick up oxygen and carry it. The red blood cell can carry it, but it can't get rid of it. So you can get, children will get bluish in appearance, trouble breathing. So avoiding it in those younger kids is recommended. Don't use in children who have a perforated tympanic membrane. And then it can be used every 1 to 2 hours, so if you've got, and it probably shouldn't be used for very long, for a day or two, because they should be starting to respond to what other product you're using. Okay, I wanted to just make those points about that benzocaine. Okay. All right, so let's talk about the antibiotics. Okay, so for acute otitis media, here are your big three, your strep pneumoniae, your H. influenza, and your M. catarrhalis. So you've got 2 gram-negatives and a gram-positive. The problem with these is because the ear infections are so common in kids and the overuse of antibiotics that there's lots of resistance to these drugs. So did Dr. Berryhill talk about observational waiting versus using an antibiotic? Okay, did he tell you it was controversial? Yes, you will find, it'll just depend on where you practice. So some people just go ahead and treat. The guidelines I read, if you look at the American Academy of Pediatrics, they have that watchful waiting in there. You read other groups and they're like, forget it, the failure rate is too high, and so it's very rare unless you've got mild disease and parents who are willing to do the watchful waiting. Most people recommend, or other experts, I shouldn't say most, other experts recommend go ahead and treat. Okay, so risk factors. So with strep, it's so knowing where your child is when you're treating them will tell you maybe what more likely the bug is. So daycare attendance, if they've had an antibiotic in the past 30 days, or they're under 2 years of age, then you can assume that the strep is probably resistant, or the bug you're working with is resistant. If you also have a concurrent conjunctivitis that is purulent, you should assume it's H. influenza. Okay, so initial antibiotic treatment is going to be based on the bugs and what your antibiotic will cover. Acceptability. Y'all had if you've had kids or if you've even had to take these things in the past, some of them are nasty. They just don't taste very good, and some of them aren't half bad. But palatability, remember we talked about med adherence, that being one of the big things with kids. Okay. We don't want side effects, we don't want to make them toxic. Most of these drugs are fairly well tolerated, except it gives them diarrhea, because you're knocking out the flora, the bugs that are in the gut, and so diarrhea, a very, very common side effect with these agents. And then convenience of dosing, so you don't want parents who are stressed and overworked and tired, not sleeping, to have to dose a drug, multiple times in the day, especially if they're going to school. And then cost. So those are the things we would keep in mind as we select. Okay, so these next sections are really important. So amoxicillin is first line because of these reasons. It's very effective, its coverage is great, and it's narrow. It's one of the few times we'll find that. It's very narrow in coverage, but it covers the bugs we want it to cover. It's very safe. At this point it's generic, it's relatively inexpensive, and we've got that great spectrum, but that's very targeted. So low risk for amoxicillin resistance. So these three things are important. They haven't had amoxicillin or a beta-lactam antibiotic in the past month. They do not have that concurrent pruritic conjunctivitis, not pruritic, purulent, sorry. So if that's the case, we're probably have H-fluenza that produces beta-lactamases, so amoxicillin by itself won't be enough. You'll have to use it with the clavulanic acid. And they do not have a history of recurrent otitis media unresponsive to amoxicillin. Okay? If they do, then we would use the amoxicillin and clavulanic acid. The dose, 90 milligrams per kilo per day in 2 divided doses. That would be another good dose just to memorize, because we'll see it over and over again. We've already talked about it twice in this class, so be another one to keep in mind. Okay, so those are fairly straightforward kids. They haven't really had a lot of ear infections. They haven't been sick in the recent history. So these are kids that amoxicillin is probably going to do the trick. When do you use the clavulanic acid? So remember, the clavulanic acid, it's a beta-lactamase inhibitor. So a lot of the resistance of those of the bugs that are common in otitis media and the antibiotics we use, they have adapted to our use of antibiotics and can make these beta-lactam destroyers. So those penicillins are beta-lactams. That's where that term comes from. And the organisms have developed a mechanism to destroy them. So now if we put clavulanic acid with amoxicillin, which is a beta-lactam, now we can resist the effects or the efforts of those bacteria to destroy it. Okay. So let's go back. So we're going to do this combination when we suspect resistance. So if they've had an antibiotic in the last 30 days, if they've got that purulent conjunctivitis and we're thinking that's H-flu that's causing the trouble or is involved, or they've had a history due to that organism in the past, then we're going to use this combo. So really, you just have to learn one set of criteria. It's either it's absent or it's present. Dose is the same. Now, you will see, hold on, Stephen, I'll get to you. You will see doses based on clavulanic acid and the amoxicillin. Just go with the amoxicillin, because that's the drug that's going to be effective, the part. Okay, Steve.
Why would you not use a non-beta-lactam antibiotic?
Because these are cheap and they're still very good. They're just, and you've still got that narrow spectrum, so you're not wiping out a bunch of other bugs that are causing the trouble. So it's the spectrum of activity that is so attractive and that we want to preserve. This combination causes lots of diarrhea. I mean, it's distressing, the amount. And so warn the parents, if they've never had it before, warn them that that is very likely to happen. If they could take it with food, that would be the best. Less stomach upset, and just be aware of the likelihood. Okay, penicillin allergy, of all the antibiotics, that's where most of the allergies are going to exist. And there's a lot of them, and it's frequent. And patients are going to tell you, I'm allergic to that drug. Allergies to a layperson means that drug caused me problems. For a healthcare provider, it's a very narrow thing what an allergy is. What lay people are usually talking about are side effects, adverse events. So whenever you hear someone tell you, I'm allergic to that, get them to describe, tell me what happened. Now, you don't have to say you're not allergic. You could tell them, this is not an allergy, this is what this is. Then you can put it down in the EMR correctly. Okay. With antibiotics, you want to nail it down because you start putting allergies with everything they tell you that it didn't, cause them problems, you'll be running out of drugs to use. Okay? So that's a really important part of the history to make sure that you've heard enough that you can make a call. So when we're talking about hypersensitivities, there's 4 or 5 different types of hypersensitivities to drugs caused by different things. Type 1 hypersensitivities are the most life-threatening. So this is what anaphylaxis would be. Sudden onset, or within an hour of onset of taking a drug. Sometimes with oral drugs it can be delayed depending on how fast they absorb it. But anaphylaxis usually starts suddenly, and it goes rapidly, and it is life-threatening. So that it usually involves the skin, usually have generalized hives. It can involve the lips and the eyeballs, and they can get a lot of swelling in that area, the tongue. They can go and have respiratory arrest because they can't breathe. They also may drop their blood pressure to the point where they would faint or pass out. And they may have GI symptoms that go along with it, where they would have vomiting or a lot of abdominal cramping. If you have that type of hypersensitivity, then you have to move away from that class of drugs altogether. Okay. Now, if they have had, yes, you probably had an allergic reaction, you had a rash, but it wasn't hives, and it was minor and self-limiting, then you're still not going to use a penicillin, but we can use a drug that's very close cousin to it. Okay. Questions about these? Very important. Okay, so here we go. We've got hives this is on a baby's leg, and then here, this is angioedema. It can be life-threatening because that tongue can swell up just like what you're seeing on those lips. Okay? Anytime you see angioedema, you got to think life-threatening. And there are hereditary forms of angioedema. They're not very common, but there are a lot of drugs that can cause angioedema. It's impressive, isn't it? So if they have a type 1 hypersensitivity reaction, you're going to avoid the penicillins. You're not going to use cephalosporins either. So cephalosporins are a first cousin to penicillins. They look similar, and in the body, the immune system will recognize them as same. And there's what we call cross-reactivity, which means you never saw the cephalosporin before, but because you have a significant immune response already built up for penicillins, you may react to the cephalosporin as well. So 80–85% of people don't cross-react, but a significant number do. So the way to separate those out is what was the level or severity of the hypersensitivity. For these folks, if they've got a type 1 reaction, then macrolides. So macrolides these are the mycins, see? Erythromycin, azithromycin, clarithromycin. Okay, or you can use clindamycin. It is not a macrolide, it's a leukocyte. It's a different class. These are fairly good drugs, but they are nowhere near as good as the others. So you do want to reserve these for kids who fall into this more unusual or this severe type of reaction. Clindamycin, later in your handout, I've got down that it tastes like sweaty socks. It's awful, and there's no way to make it better. So if you can use one of the other agents, that would be good. Usually, erythromycin is really hard on the stomach. It causes lots of vomiting, lots of stomach upset. So going with azithromycin or clarithromycin is probably more preferable. Azithromycin can actually be used over a shorter period of time. It's usually about a 5-day treatment. So that seems to be the go-to that if you have to use that class of drugs that people will use. Questions about that? Okay, so what do we do if we've got a non-type 1? No signs of anaphylaxis. Still don't use the penicillins, but what you can do is use the cephalosporins. The second and third generation cephalosporins are pretty good. They're better gram-negative coverage. Their gram-positive isn't great, but it's not bad. So you can use those. They're palatable. Omnicept is Cefdinir, and it has a red dye in it, and it will turn their stool red, so just caution them. Hopefully the pharmacist will as well, so they don't feel like the child is bleeding. And it'll go away once they quit using it. Okay, so any questions on choice? Yeah.
Is there ever would you ever use more than one second or third generation antibiotic for greater coverage if you didn't use the primary?
I don't think so. I don't think they do. I think they're fairly responsive. It's when you get into prophylaxis that, and they still just use one. Not that I know of. That would be for someone who's more experienced than I am, but from what I've read, no. Okay, so in assessing therapy, if they cannot tolerate the medicine or they're vomiting it up, then you can go with ceftriaxone, which is a cephalosporin. It's IM, it's one dose, unless they they failed antibiotic therapy, then you would go with three doses. Duration of therapy, there's a little box on page 6, middle of page 6. So how long we treat them looks like this, is based on their age and the severity. Okay. So the younger they are, the longer we treat, and the more severe, we treat everybody 10 days. You should see a good response in 2 to 3 days. Sometimes I read where it gets worse before it gets better. I'm not sure what the reason is for that. But usually at 48-hour mark, you should be seeing the child respond. If they fail amoxicillin, so if you have failures, here's kind of your path. If they fail amoxicillin, then you would try amoxicillin clavulanate. If they fail both amoxicillin and a cephalosporin, then trying the ceftriaxone, which is the IM form. If they fail that, you could try clindamycin plus a second generation or third generation. So Stephen, here goes where you would do this. I would say probably most people at this point are already writing out a referral and having somebody look at. Did he talk about there being, if you have 3 episodes of acute otitis media in like a 6-month period, they usually then start looking at tubes? Did he give you a criteria? What was his criteria? Did he use that?
I think he said 3 years.
3 in 6 months or 3 in a year?
No, I think it was 6 months, 3 months.
In 3 months?
No.
Whoa.
Because you've tried antibiotics for 3 months and nothing's changed.
Yeah.
Okay, so that's no difference. What if you have discrete episodes? Did he give you anything there? Okay. So I'm going back, this is a slide that I had for you when we talked about pediatrics. Just palatability, remembering how to make the medicine go down. Did y'all see Mary Poppins when you were kids? Did you? So you know the little song. Okay, so.
Oh my God.
So the chocolate chaser before and after is really good to coat that tongue. A lot of pharmacists will ask you about flavoring a medicine, especially for a child. Remember the Medi bottle that has the syringe inside the bottle that you can depress as they're taking their formula down, and then also the pill cups would be a little bit older children. And in special populations, this is just a reminder, especially for obese kids, that we still don't exceed the adult dose. And for adults, we use the same kind of guidelines. You just don't see it as often in adults population, but we're going to use the same approach in antibiotics that we would with the kids. Okay, any questions about those? Anything that Dr. Berryhill told you that And contraindicated, okay, good. Okay, so let's look at chronic suppurative otitis media. Again, we don't tend to see it, tend to see it more often in kids, not as much in adults. Common bacteria are similar to what we already have talked about. Pseudomonas here is the more common though, not the staph and strep. But you got other gram-negatives with Proteus and Klebsiella. Your gram-positive, still your strep, and then you got anaerobes start to come in. So your Bacteroides, your Peptostreptococcus, and your Peptococcus. So that may change how the antibiotics we're going to use. Here they recommend the ear irrigation at least several times a day to keep all that junk from building up. And here we're going to use a quinolone. So it's for the Pseudomonas. So they're good against the gram-negatives, gram-positive, and they've got very good Pseudomonas coverage. So here, the systemic antibiotics are recommended if you get somebody who's just not responding to therapy. So the major complication here is when you go on to acute mastoiditis. Very common, more common complication in kids than adults. And here it's just a whole bag of organisms. So your gram-positives, your staph and your strep, your gram-negative Pseudomonas, your enteric gram-negative rods, and Haemophilus influenza. So a gram-positive, gram-negative mix. With the layout of treatment, it just keeps building. So it's fairly easy. Vancomycin is always used. So because you've got staph and you're dealing usually, until you rule it out, you're going to assume you've got a methicillin-resistant staph. So if you've got a patient without a history of recurrent otitis media or recent antibiotic therapy, the gram-negatives your vancomycin will cover it. It's excellent. It's the most powerful one of the most powerful gram-positives we have. If they have a history of recurrent otitis media within the last 6 months or recent therapy, and they do not have a penicillin allergy, so you got those 3 things to keep in mind, then you're going to go with a vancomycin and you're going to add a cephalosporin. Or you can use a piperacillin tazobactam. That's a very powerful antibiotic. I think most people would go with the other 2 first, unless there's a compelling reason. So when you look at that antibiotic regimen, it covers about everything. Now, if you have somebody who's got that type 1 hypersensitivity to a beta-lactam, then you're going to use acetrionam, which is a monobactam, and vancomycin. There you've got very good gram-negative and MRSA. Again, not as great, but you do have gram-positive and gram-negative, so it's actually pretty good. Acetrionam is a good antibiotic. For patients with a non-type 1 hypersensitivity, then you can go with vancomycin plus one of your third or fourth generation cephalosporin. Treat for 4 weeks. Okay, so I'd keep those those indicators in mind. They're the same for almost every situation we've already looked at, and then add your antibiotics on. If you can kind of get in your mind, here's the bugs I'm treating, and here's what the antibiotics are going to do, I think it will start to make sense. If not, just memorize them straight out. You're going to see them come back over and over again.
Are both of those for 4 weeks?
All
Okay.
the total 4 weeks, yeah. Now, that's kids. In adults, it's a 2-week recommendation is what I found. So in adults, it's strep, HV influenza, and what I found is that for the staph, it's usually methicillin sensitive staph. So the antibiotics here are your cephalosporins, because your coverage is really good for gram-negative and gram-positive. Or if they are allergic, then you can go with the either the fluoroquinolones or doxycycline. and then switch from oral therapy to oral therapy once they're responsive. That could be 3 to 5 days. And then the duration here is only 2 weeks. Questions or comments? Okay, so those are our infections. So we're going to end up with the vestibular neuritis and then Meniere's disease. Anybody had vertigo before? Can you describe what it was like?
I mean, I only had it after I got a shot. And so-
Oh, really?
Yeah.
Okay,
And I just,
so how did that feel?
I lost control and fell down.
So did you faint?
Yeah.
So you had more like a vagal reaction maybe?
Yeah.
Okay. Did you say you had, okay, what did you experience?
I have no idea what the trigger is. It happened for just a few weeks, where I would get like a really strong ringing in my ear, and then all of a sudden it just felt like I was moving like this. I know it happened actually in lab one time. I was talking to somebody, I don't remember who was in here, and I mentioned it because I thought I was gonna fall down, but this is just a few weeks ago. But it went away. I'm good.
Okay, anybody else ever have vertigo? It's a weird feeling because you are still, and you know you're still, but everything moves around you. So it's very disconcerting. I've only had when I had that benign paroxysmal vertigo, but it would always be when I would turn over in bed, and then the room always spun in the same direction, and it would last about a minute, and then it would go away. But yuck. So anyway, so the vestibular neuritis. Now this section is thought to be post-viral, viral or post-viral inflammatory condition. The antivirals don't seem to work, so we don't use them. We're going to focus more on two things. So we're going to focus on the inflammation part, and for that we give a steroid. Have y'all talked about steroid tapers? Has that come up? Have you ever been on a steroid taper? Ever had a Medrol dose pack given to you? Okay, that's a steroid taper. It's a packaged steroid taper. So similar, a lot of people will use that, or they'll use prednisone. In the Medrol dose pack is actually methylprednisolone. And it is a prodrug, and so we give it in very small doses. The body converts it into actually the prednisone. So what you do is you start off with a big dose, blasting, and you're just decreasing over time. Here you can go 5 days without doing much adrenal suppression, and then you taper it off so that you don't leave so you can give the axis time to recover. So this is a 10-day taper. You're usually going to give them 5 or 10 milligram tablets, and you would tell them take 6 tablets the first 5 days, then start taking 1 less every day until you get down to a half tablet a day. So it's usually about a 10-day. We usually tell folks to take it first thing in the morning. Do you know why? When's your cortisol levels highest? Do you remember?
In the evening.
It's about 2 to 3 or 4 o'clock in the morning, cortisol levels start to rise, and so they peak out in the early mornings. So we give that big dose in the morning because it doesn't cause as much adrenal suppression. There's already high levels, you're putting other high levels, so the negative feedback to your brain and the adrenal glands is like not as much as if we give it at night. It can upset people's stomachs, so we'll often tell them to take it with food. Sometimes that much can make them really sick to their stomach. Okay. So that's going to treat the inflammation. Now the other part, the vertigo part, there's lots of different drugs that can be used. What I have given you is here is the drug classes, and I've given you a representative of that class. There's quite a few. You also, which I can see can be confusing, is that in the antihistamine group, some of them are called anticholinergics. So you'll see them referred to as different things in different text. So antihistamines, this would be like meclizine, diphenhydramine, Benadryl, Dramamine. Any of your parents ever give you Dramamine for car sickness? Okay. So that's what that diphenhydramate is, or it's a derivative of diphenhydramine. That can be used for just that, so these folks can get really, well, if you've been dizzy, if you ever wanted to throw up, or sometimes those two things will go together. If they get so dizzy, they may want to vomit a lot. So giving them this to arrest that vestibular activity and also to decrease the nausea feeling, you can use the antihistamines. Scopolamine, have you ever used those for like seasickness? Gone on a cruise or a ship ever? Sometimes they'll have you wear a transdermal scopolamine patch. That can be used for motion sickness as well. The benzodiazepines, they'll try to stay away from. They're fairly sedating, and long-term use, they can have some withdrawal effects. So, but Xanax is very short-acting and can be used for short periods of time. Antiemetics, we talked about on Dancitron before, Zofran, so that can be used. There's quite a few others. It's probably one of the easier ones to use. So in the emergency room, they could give it IM, they could give it IV, but it also comes in a tablet that you could send them out with. Okay. Meniere's disease, very debilitating disease. One of my classmates in graduate school had this, and when he would have those attacks, it was just very disconcerting to watch what he went through. So vertigo attacks, I don't know how to say the word that, what do you call the pathology part of that inner ear? Is it an inner ear or is it a middle ear? Inner ear. So what are those, no, the lymphoid, say it again?
Endolymp?
Okay, it's one of those, I heard the video. Okay. So we want to maintain balance, because they often have very difficult time maintaining balance during an attack, maintain their hearing, decrease the tinnitus that goes with it, which is a very disturbing when you have it. Minimize any disability and then prevent disease progression, particularly their hearing and balance. So there seem to be a lot of dietary triggers associated with Meniere's disease. So you'll see recommendations for them to, one is to decrease their salt intake, and we'll use diuretics to actually address that, but also the fluid that is building up in those areas seems to be or the edema seems to be part of the problem. So limiting caffeine and alcohol, which have effects on the inner ear, reducing stress, nicotine. It's kind of like a broad gunshot, but you'll see those recommendations for each of those to at least limit them. Let's see, I think this is most, these are written out for you. So just avoiding those or telling them to cut down. Or if they can identify a trigger, that's a good thing for them to recognize and then to avoid on their own. So with the acute episodes, we're going to use those same drugs we just talked about to treat vertigo. We're going to use them. The one difference, which doesn't always make sense until you understand the pathophysiology, is to use a diuretic. So hydrochlorothiazide is a diuretic, and that would be the drug of choice. It's very inexpensive, easy to take, and with very low side effect profile. Antiemetics, again, meclizine, dramamine, or the diphenhydramate can be used. Anxiolytics can be used, and these would be the longer. Again, they would probably go with something beyond if they didn't want you. You would want to avoid having to use an anxiolytic all the time, but if you had to, they're certainly effective. And then for those who have allergies, using a second generation antihistamine like loratadine. And I think that's it. So did you feel like, has it helped to hear it and then hear the treatment right after?
Yes.
Okay.
Kind of.